This is part 2 of patient assessment. We're going to continue on with our secondary assessment. So we've got our sample history out of the way, but we've asked some questions. We try to get that done very quickly, especially if we think the patient could go unresponsive and there's nobody else there to answer that for them. So we get that done. Secondary assessment now is to assess non-life-threatening conditions. You took care of the ABCs in the initial, and now we can get more information from them. And you may want to do this en route to the hospital. It just kind of depends on your scene time. So when we get signs and symptoms from a patient, a sign is something that you can see, smell, touch, or hear about your patient. It's pretty objective. Everybody kind of agrees on this. Whereas a symptom is something that the patient tells you. So if the patient is nauseated, you can't really see that they're nauseated, but when they vomit, now you can see and smell it. If they had a headache, you can't really see that, but if that headache was causing high blood pressure, then you can see that as a sign. So the difference between the two. So we're going to use a systematic full body assessment to look and touch, and then with our stethoscopes, listen to the chest, listen to lung sounds, and we're going to look for deformities, open injuries, tenderness. When I touch, they say, ow, that hurts there, that's tender. Or anything that's swelling. One of the best ways to look for deformities and swelling, especially in an extremity, in an arm or a leg, is to compare one side with the other side. And we look and go, wow, that looks swollen, but the other one does too, and you're not complaining of pain there. Maybe it's just a little bit of edema. Your full body assessment can be done on the patient whether or not they're conscious or not. And your full body assessment, starting at the head, working toward the toes, we call it a head to toe assessment, especially for patients that are injured and could have multi-trauma to them, different parts of the body. So our partner is going to stabilize the head and spine, and we're going to do this in class. We do a patient assessment skills practice, touch and feel each other, and it should take you 60 to 90 seconds to complete this. Remember, you're not looking for life-threatening problems, you're looking for non-life-threatening, so it should go pretty quick. It should be performed on all patients who had significant mechanism of injury or unresponsive. So rapid head-to-toe assessment. Now your focused exam is like a rapid head-to-toe assessment, except for, well, they fell and broke their ankle or hurt their ankle and it's deformed. We're not sure if it's broken. And they hurt their ankle and you don't really see the need to do a rapid head-to-toe assessment. All you want to do is look at the ankle, compare it with the other ankle. We call that a focused physical exam. Your responsive medical patients, the scenario I gave you with the man with the chest pain, I would listen to his lung sounds and I would look in his extremities, especially in his ankles, to see if he had any swelling. That's about it. I don't need to touch his head to see if it was broken. And it's all based on the chief complaint. After we do our physical assessment, we're going to assess vital signs. Now, we've already been on scene now for 4 minutes. You're like, wow, this sure took a long time before we got a blood pressure. Well, if you're with a team, you have a partner while you're doing the questioning on the sample and the physical assessment, your partner can take the vital signs. So we want to check respirations and pulse. Again, I showed you if you check respirations for 30 seconds and then check pulse for the next 30 seconds, or remember those numbers and multiply those by 2, they don't really see you looking at their chest, checking their breathing. But you get a lot of information. We call these baseline vital signs because we're going to continue to take them every 5 to 15 minutes. And from this, you can see if your patient's getting better or worse. So when you report respiration and pulse, it's always very good not only to report the number, respiratory rate of 18, heart rate of 72, and don't round, don't make them, 20 and 70, unless they actually are 20 and 70. Make them what they are. That gives me some information, but it would be better if you said respirations of 18, regular, nice regular breathing, and non-labored. Whereas if you said pulse of 72, strong and regular. Now I know a whole lot more information about that patient. If the patient's unresponsive, then I'm going to check a carotid pulse, and normal heart rate for the adult is 60 to 100. Cap refill is also very good to check for circulation. It's very accurate in kids less than the age of 6, not so much for adults, but you can still check it. We squeeze the patient's nail bed for 5 seconds, and then we let that go and we count how many seconds that nail bed takes to return to its normal skin color, which is pink, and it should do that in less than 2 seconds. We're going to get a blood pressure. So in vital signs practice, and that's why we did it early, so you can build that technique. We're going to practice again at the next class. You check the top number and the bottom number. So the systolic, the top number, measures the pressure exerted on the arteries when the heart is contracting. And the systolic measures the pressure on the arteries when the heart is resting. Anything over 140/90, either number, makes it hypertension. And we like to see that blood pressure is at least 90/60. That's kind of our minimum for the adults. At the same time, we can get so much information by just looking at the skin. Color, temperature, and condition. The moisture. Is it very dry and flaky? Is it 72 degrees in their house, nice and cool, but they're just sweating, their skin is very cool, and they're pale looking? Well, that's a sign of shock. That's not very good. So again, just to say the skin color is good isn't enough to say that they're warm and dry. That's good. Not dry, flaky, just not moist. Depending on their injury, we might want to check pupil size, especially if they had evidence of a head injury, maybe a stroke or drug overdose. And we'll take a pen light, we'll shine it into one eye, and look at that eye get smaller, constrict. Then we'll shine it into the other pupil, watch it constrict, and then I'll do that again, but this time I'm going to look at the other pupil because they should constrict together. Here's an example of a normal sized pupil before the light is shined into it. In the middle is a dilated pupil, especially if you shine a light into that middle one and it doesn't constrict, then that's abnormal. Or if it's already constricted, especially if the room is very dark, that's an abnormal state. That could be somebody that maybe had drug ingestion. If anytime you see unequal pupils, then that's also a sign of maybe a stroke or an injury to the brain. Unequal pupils is not a good sign. And then we're going to assess level of responsiveness. So, hey, wait, we already did that, didn't we? Well, this one you can actually get more information and decide. It's not so much you're asking them any further questions, but just by asking the patient all of this, you can say, wow, not only were they awake, but they were very alert. We call it alert and oriented times 4. They knew who they were, they stated their name, they know what day or date it is, they know where they're at, and they can tell you what happened. So we can look at that ABPU scale. So your secondary assessment after the primary assessment consists of the sample history, very brief but very inclusive, your trauma or focused exam assessment, some kind of physical exam, whether it be you're looking at the injured ankle or you're doing a rapid trauma assessment of the full body, some kind of physical exam to see what you can find. On your physical exam, don't forget the back. If you don't log roll your patient or somehow assess their back, you're missing 50% of the body. So make sure that you do that. And then that baseline vital signs, because we're going to continue that. In the reassessment of the patient, we want to repeat that primary assessment. How you doing now? Oh, pretty much the same. Okay, well, they're awake, their airway's open, their breathing is good, their circulation is good. Check that pulse. We're going to continue to monitor the vital signs, as well as skin color, temperature, and condition. We're going to document all of those. And in that documentation, you're going to trend that patient, TREND, to see if they're getting better or worse, or staying the same. Reassess their chief complaint. You know, how's that ankle feeling? I put some ice on it. You know, I agree with you, it's probably broken. How's it feeling? Oh, it's kind of feeling numb. You know, assess it. And then recheck the effectiveness of the treatment. If you bandage something and now they report that they're feeling numb, maybe it's too tight. Maybe you gave them oxygen and it just doesn't seem to be working. Maybe your oxygen tank ran out of oxygen. Maybe you have them on portable and you need to change them over to something else. If you see changes in their condition, identify it, and if need be, treat it. We're going to reassess a patient who is stable, delayed kind of patient, every 15 minutes. If a patient is unstable, we're going to reassess them every 5 minutes. Now, I know this sounds crazy. Every 5 minutes. It takes me 2 minutes to do vital signs, and you want me to do this every 5 minutes. That's all I'm going to be doing. If you have an extra person there, that's all they're going to be doing is documenting those vital signs. We're going to prepare a handoff report. So if you're first responding, you can't remember all of this stuff. You know, what was the first blood pressure? What was the last one? You're going to have some form to document on get the patient's name, their gender, their date of birth, what happened to them, their chief complaint, their level of responsiveness, as well as their vital signs, anything that you found in the patient assessment, their sample history with that bag of meds that you're going to hand off to them, and then any interventions that you provided. All that is great information. That saves the crew that's responding so much time. You've already done that. Hey, let's load up the patient. Let's do the rest en route to the hospital. You've done all the hard work for us. If you're with an ambulance crew, then this is what you'll do. Maybe the primary assessment, and then load them up in the ambulance and do the rest en route. Boy, that would save a lot of time, especially if you have a long distance that you're transporting to. So on the reassessment, your paraphrase looks like this. My reassessment, I will check initial assessment, vital signs, physical findings, interventions that I have provided every 5 to 15 minutes. A little word about medical and trauma patients. So we think of two main categories: somebody who had a sudden illness or somebody who sustained trauma. You have to remember, sometimes people have both. Somebody's up on the roof putting some new shingles on, and their blood sugar drops, and they become hypoglycemic and altered mental status, and then they fall off the roof. And you're like, so you have to ask yourself, why did they fall? Did they trip over a bundle of shingles? Or did they have a medical condition first that caused that to happen? There's no rule saying that patients can't have two things wrong with them. So that's where your medical history, that's where that sample comes in really effective. Avoid jumping to conclusions. You don't want to fill in the blanks there. If it's not there, it's not there. You know, if they say I had trouble breathing and you listen to lung sounds and they sound clear and equal, you report, I heard clear and equal. You can't make things up, yeah, they were a little diminished, because they look like they should be. You report what you saw or heard. So your complete patient assessment consists of the scene size up, the primary assessment, the secondary assessment, which includes the medical history, that sample history, and then your reassessment. And if you learn those in those groups with those steps and the paraphrases, you will not have any problems with patient assessment. In that primary assessment, you're trying to figure out life-threatening problems, and you fix them. You don't go, oh, looks like he's got a lacerated artery that's bleeding a lot. I need to make a mental note to come back and check on that and treat it. No, we're going to treat it right away. That systematic approach, as well as treatment of the patient, head to toe, is what's going to really help you in that handoff communication. So remember, if they're stable, repeat vitals, and as well as your reassessment every 15 minutes. If they're unstable, every 5 minutes. A little bit of a review. Which of the following steps might be performed during the scene size up? So remember, you haven't touched the patient yet. And I will have to tell you this, with test questions, whether they be on your Jones and Bartlett site or the tests that we're giving you at the modules or your national registry, patient assessment is one of the hardest ones, because you have to think about where you're at in that scenario. And I'll show you as we go through these 3 questions how that works. So in the scene size up, you have not touched the patient yet. Assessing vital signs using appropriate monitoring devices. Nope, haven't done that yet. I'm in the scene size up. Forming a general impression of the patient up. That's my first step in the primary assessment. So nope, haven't done that yet. Notify dispatch to send fire personnel. Wow, that's under, do I need additional resources? So that's a yes. Performing full body scan. Nope, have to touch the patient to do that. So that makes it a little bit easier if you think about where you're at in that scenario. The goal of the primary assessment is to quickly diagnose. Oh, there's a word right there that throws that one out. We don't diagnose in the field. Determine the need to perform a full body assessment. Determine the need. Well, the need is going to be based off the mechanism of injury. Determine the number of patients. No, I did that in the scene size up. Identify and treat all life threats. Ooh, I like that one. That's what a primary assessment is for. Identify and treat life threats to ABCs. After performing a primary assessment and treating any immediate life threats, you should next, I love this question. So you have to think of where you're at in this scenario. So think of going to a mall or someplace that has a board that says you are here. So after I've done my primary assessment, it says, what do I want to do next? Determine the priority of the patient in transport. Man, that sounds pretty good, because I've already finished my ABCs. I found the life threats and I treated them, and now I need to make a decision. That sounds pretty good. Reassess the patient. Now I'm going to do that in the reassessment after I've done everything else. Recheck your intervention. I'm going to do that in the reassessment. promptly transport them? Nope. So the best answer there is determining the priority of the patient transport. And that's why I like these questions in here. And I hope you're taking advantage of the ones in the Jones and Bartlett chapters too, because you have to stop and say, well, where am I? I've already done that. If I'm here making this decision, I've already done all that other. So that makes it a lot easier.